Hi Bio4 and welcome to part 6 of urinary. We were finishing up on the nephron on this slide looking at secretion, and we move on to a very simple slide here that has all three mechanisms shown, so you can get a good idea here as a review. So the review is showing you that filtration is happening in the glomerulus. Reabsorption is when something goes from what was in the filtrate, right? This is to become urine, and leaves there. It gets reabsorbed into some little capillary that is traveling right here. So reabsorbing is out of the nephron and back into the blood. It also happens here. It also happens here. And it also happens here. It happens everywhere. Okay? Everywhere there's reabsorption. The only place where there's not reabsorption of fluid is in this region here. But there's one form or another of reabsorption happening throughout the nephron. So we know what filtration is, we know what reabsorption is, and now secretion is the opposite direction. It's from some little capillary that's here, and allowing it to pass directly without being filtered straight back into what will be urine. So it's kind of like this is dumping and this is recycling. This is saving and this is dumping and this is filtering. Okay, if you can say it a simpler way. All right, let's look at the anatomy of the ureters, and this is of the bladder, and we'll do it in the female and then the male. So look at how the ureters, when we're looking at it in anterior view, you see the ureters are coming in posteriorly, right? I'm going to just pretend there's an opening here and opening in here. And so this is, oh, I'm sorry, look, they're right here. Further down, I couldn't see those. Okay, so it's coming in here. Let's erase my other ones. And let's erase this in here. So these are the ureteral openings, and it's coming in then posteriorly. And the other interesting thing is that it's coming in at an angle. Okay, so that angle here is going to make it so that it's harder for backed up urine to actually make its way back into the ureters and back towards the kidney, causing infections. We'll see a little bit more about that later. So entryway here into the bladder posteriorly. This sort of triangle that was drawn in is just to show the cone shape that exists in this funnel-like area, which is funneling urine into the urethra. So if you can imagine it three-dimensionally, it's a cone or a funnel, and it's bringing that urine down into the urethra. Okay, two important structures here are sphincters. So a sphincter here is going to allow you to tighten this muscle up and not let urine flow, and tighten this muscle up and not let urine flow. So we have two of those urethras. One is the internal ureteral urethra and the external urethra. Ureteral sphincter, sorry. Two sphincters. So why do we have two sphincters? We actually have control of just one of them, and it's this external sphincter. So when the bladder fills, let's make this bladder full here. When the bladder fills, it's going to create pressure on the sphincter, and urine is going to start coming down. And it'll start and it'll fill this region here, but you have control over this. So you know that you need to avoid, but it's not a good time. You are going to contract that external sphincter and not let that urine go anywhere until you are in a place where you can do so, in a bathroom, and you will open that up. In kids, in little kids, a 1-year-old does not know how to control that external sphincter yet. So the learning, the potty training, is all about the control of this external sphincter. Okay, so the pressure here is going to give that mechanoreceptor that sensation of fullness. Okay. In the male, the same ureteral openings here, and the trigone still, internal urethral sphincter, and then the external here. So big differences here is that we have a prostate gland between those two sphincters, and then a longer urethra. So those have, we'll come to it, different names depending on what section of the urethra we mean. Okay. This is in words for you to have these notes. The ureters are going to connect the kidney with the bladder. One question that usually arises is, well, how does it descend? Well, the ureters have their own contractions. They have peristaltic contractions, so they're able to actually squeeze and bring that urine down from the kidney down into the bladder. There's also gravity that's going to help, and just hydrostatic pressure, which is just the pressure of the volume of that fluid in that location. And all those will aid in the descent of that urine into the bladder, into the urinary bladder. I had mentioned to you that it will enter the bladder obliquely, and so that oblique entrance serves to prevent backflow of urine. So when the bladder is full, you don't want this to create a kidney infection from the urine that actually traveled backwards. The urinary bladder stores the urine. The wall of that bladder is complex. It's formed of 3 layers of muscle in different directions, and by having these longitudinal and circular layers of muscle, you're able to contract that bladder. So it's very useful for the contractions and elimination of the content of the bladder. Those 3 muscles together, if you just pull them together into one, we call them the detrusor muscle. And the detrusor then, functioning well, will squeeze the bladder for you to void. The trigone I had mentioned, it's the funnel that channels that urine into the urethra. The micturition reflex is what empties the bladder. So there is, once that, let's go back. Once that second sphincter is opened, then the next is kind of like a reflex where we have a contraction here. The bladder will squeeze that urine down and it will exit through the urethra. So it sort of falls into place once that external sphincter is open. Volume in a male, I mentioned it in a male because it's larger. It can hold up to 800 milliliters in males, slightly lower in females, about 600 to 700 in females. And there is, again, the picture for you to look at all the structures. One other structure that's important to think of is the pelvic floor muscles, especially in females. These should be strengthened. What happens with aging is that, look at this anatomy, the uterus here can put pressure on the bladder that in turn puts pressure on this muscle. And so the pelvic floor muscles are going to help with the maintaining the tone of that sphincter. And if that sphincter tone is gone and the pressure of this dropping is going to create problems with urethral leaking. So it can happen, you know, the individual sneezes and they lose a drop of urine or something. So it's just the leaking, which is not something that's wanted, happens in individuals with a weakened pelvic floor muscle. Okay, I've mentioned this to you. You have it there written so that you can consult it, the external and the internal urethral sphincters. This is in the male, again, to show you the location of the prostate gland. So the prostate gland here between both sphincters and also with the ability to compress the urethra. And we'll talk about that with the pathologies in the pathology section. The regions of the male urethra, it's all one urethra, but it has different names. Prostatic urethra in the region of the prostate. The membranous urethra in the region of the base of the abdominopelvic cavity, and then the penile urethra from the urogenital diaphragm to the tip of the penis. So just all one urethra, but with different names, just so as to know what section of the urethra you're referring to. So prostatic urethra, region of the prostate. And here we have penile urethra. And so the membranous urethra is here, and then the rest is penile urethra. So here, the pathologies, this video is going to be a little bit longer, but we'll just finish up with it. And this is very common, benign prostatic hyperplasia. So this is the enlargement of the gland, of the prostate gland, after age 50. We don't know why that happens. This is not a cancer. This is a condition in where the prostate just starts to enlarge. We know that at puberty, the prostate actually doubles in size. It's going to provide semen, correct? It's going to be manufacturing semen in the male. And so at puberty, this gland is going to grow. After age 25, it starts to grow again. And that prostate could potentially constrict the urethra. So here we have pictures, normal prostate. Here's the urethra, no problem, there's a passage. What happens if we have this growth and it's narrowing the passage here? So now urine that's supposed to be flowing down is going to end up staying. It could irritate the region of the bladder and give the sense of needing to void more frequently, even though there isn't much urine inside the bladder. So I've listed those for you, and I'll read them to you in a bit. So here again, prostate with the smiley face, this is doing fine. This is an enlarged prostate, and look at the problem here, causing problems both in the bladder and here in the urethra that's sort of closing off. So what are those problems? The bladder wall becomes irritated. So if it becomes irritated, it starts to contract when it has very little urine in it. Usually it would contract when it was very full. It starts to contract with little urine, and that's an aggravation because the individual needs to void more frequently, needs to get up at night once or twice, and that's an annoyance. Urine will accumulate in the bladder, and if you have it sitting there in the bladder not being able to go through the urethra, it is more likely to cause an infection. It's also more likely to create stones, which are uric acid crystals that form. All this is causing hesitant, interrupted, weak stream for this individual. Often urgency and maybe leaking or dribbling of urine. And as I said, more frequent urination, especially at night, which is the big annoyance. Not fun. So as the urethra narrows now the bladder is going to have to contract more forcefully if it wants to get that fluid through there. So over time, then the bladder muscle gets stronger. It gets stronger, it gets thicker because it's doing its work, and it becomes overly sensitive. And sometimes with that overly sensitive condition, it begins to contract even when there's very small amounts of urine in the bladder. And hence that leads to the increased frequency in urination. So eventually, bladder muscle cannot overcome that. It doesn't have enough force to overcome the effect of that narrowed urethra. So you have too much urine staying in the bladder. It's not completely emptied, and that's when infections can occur. Another nasty condition are kidney stones. And these are calcium oxalate or uric acid, as I mentioned, when they crystallize. And this is very painful, especially to males with a longer urethra, because it has to go all the way down there. And as it goes down that urethra, it's going to be causing pain all the way along the entire urethra. So what can be done for this? It can be sound wave treatment, where they try and dissolve. They hit it with waves and break it up into smaller little stones so that you can actually eliminate them, urinate them out. Or certain buffers will dissolve it, so you can try and chemically dissolve it. Or with surgery, try and remove the stones. So where would these stones lodge? Well, they tend to lodge where the renal pelvis narrows into the ureter in the kidney. Very painful. Or where there's another narrowing, which is where the ureters enter the bladder. And these are common regions to have these stones lodging. Here's a nasty picture of one. It's like an inch across, which is crazy. Often they'll have these, because they're crystals, they have these protrusions. And imagine this just sort of rubbing by a urethra. It could be very painful. And that is the end. A little longer for this last section, but I wanted to get those pathologies all in one place. Okay, thanks for listening.